Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today's topic is about manual muscle testing with athletes, especially pro athletes. If you're familiar with people who do motor point acupuncture, you attended courses, you will have learned some manual muscle testing as an assessment. And on the general population, manual muscle testing, especially when you're looking for pain, can be effective, especially things like the hip and the shoulder when you're looking for pain. But that's not what I'm talking about today. Today, I'm talking about sports performance. I'm talking about working with athletes for injury prevention or rehabilitation after an injury where they have some sort of arthrogenic muscle inhibition, etc. So the manual muscle test scale of 0 to 5 was developed in 1915, and it was used to assess what they called paretic patients, or patients with a paresthesia or an paresis. So the weakness that they were looking for is usually something like polio or some other neurological issue. If the patient could press a 5 out of 5, that was the ceiling on a paretic patient. Now, when you're working with an athlete, that 5 out of 5 is probably their baseline, the floor, not the ceiling of their strength. And in many times when I've talked about this, and for years I've been skeptical of assuming that a strong muscle test on an athlete could be trusted. But before I put that into the course I'm planning for in Australia for sports performance, I decided, let me look at the research on that, because that's always just been my experience, my own assumption when working with athletes, that I could not trust a strong muscle test. But the research is there to completely back me up. And the research for working with athletes says that you cannot trust a 5 out of 5 strength test or manual muscle test with an athlete. They did research in 1997 where they used a handheld dynamometer to find an athlete that had 15 to 20% deficit in strength, and then handed those athletes over to examiners to manual muscle test, and they would pass with flying colors at a 5 out of 5. They also determined that a male athlete being examined by a male examiner, the examiner could only use enough force to determine there was a deficit 50% of the time. And when the examiner was female, it was 0% of the time. The male athlete could always overpower the examiner. So what they determined was that manual muscle tests on athletes is saying more about the strength of the examiner than the athlete. So think about that. Manual muscle test is just exposing the weakness of the examiner and not of the athlete. So the dynamometer, it's a digital device and they're usually expensive. They're going to show pounds of pressure that you can push. Okay. It's not, in my opinion, it is not relevant for our world working with athletes that we use a digital device, because we're not trying to track progress of the athlete post injury. That is for their physios to do. What we do need to do is to understand when they possibly have an inhibition, and we need to know what to treat in spite of a 5 out of 5 strength test. So the research shows that length testing for short muscles is essential, and that we should expect the antagonist to be inhibited when there's a shortened muscle. So the pecs are tight, so the rhomboids are inhibited. The psoas is tight, and the glute max is inhibited. The research is actually talking about yanda, the upper cross and lower cross syndrome, as a better way to assess athletes to make sure that you find the inhibition. And it's not an either or, it's both and. They are saying that we need to resolve the tight short muscles and look at the inhibited antagonists. And what you'll often find, as Yanda would show, is you address the short tight muscles and you will see a stronger antagonist that is no longer inhibited. It's usually a reciprocal inhibition. There is arthrogenic muscle inhibition that happens after an injury, some sort of maybe an ACL tear or knee surgery or some kind of joint injury that sort of shuts down the signaling, because the protective mechanism, the mechanoreceptors at the joint and in the tendon of the muscle will tell the body to shut off. So that basically it's a protective thing. If you put too much strain on a muscle, the mechanoreceptors can send an inhibitory signaling that the nervous system will then stop using that muscle. So you're not going to pull it off the bone. And a similar signaling is happening after a surgery or an injury. It could be months or years later that they still have that inhibited muscle. And that's where electric stimulation acupuncture comes in for waking up those inhibited muscles. Now, when you have an inhibited muscle like that, you probably will detect the inhibition with a manual muscle test. So the researchers say, don't throw manual muscle tests away. Just stop using the 0 to 5 scale. So they're saying use the manual muscle test as a binary, as a yes or no. And don't only hold the test for 1 second. The research shows that they can fool you in 1 second, and the neuromuscular deficit won't show up unless you're holding for 3 seconds. So you have to have resistance for 3 seconds to find that inhibited muscle, especially for an athlete. The 1 second test is BS. It's not going to reveal the problem. It's a neuromuscular issue. And what they're also saying is that even with the short muscles, there is that Vladimir Yanda's tightness weakness. Part of that is that the contracture of the muscle creates pressure on the nerves, which can cause a neuromuscular inhibition as well. So we have to think about muscle imbalances, and the Yanda patterns are these researchers in multiple journals are saying this is the gold standard for working with athletes. Understand your cross patterns so that you know what muscles are short, and resolve that so that the inhibited muscles can fire better. And I would say the research shows that arthrogenic muscle inhibition is best treated with high frequency stimulation, electric stimulation at the highest level that the patient can tolerate. I won't go into that right now. The point is, like muscle length testing is, and combine that with a yes no binary for manual muscle tests, is the best thing you can do for athletes. Now, how do we know? Let's say the abductors, the hip abductors, are testing a 5 out of 5 on a manual muscle test with your athlete, right? How do you know what to do with that athlete so that they do not have a knee or an ankle injury due to an unperceived deficit in the hip abductors? Because if they have to cut left and right, the hip abductors need to be powerful, right? We've talked about this before. If the hip abductors are not as powerful as they need to be, there's more strain on the lateral knee and the lateral ankle. And you could also argue that the strength of the abductors keeps the knee from going into a valgus strain. So the hip abductors need to be optimal. So you may not like my answer. You treat them regardless. You treat the hip abductors on an athlete regardless. You don't even worry about muscle testing the hip abductors. You assume that they'll be strong. They'll be stronger than you, which is what the research shows. So even if they're weak, for them, they're stronger than you. You would think it's a 5 out of 5. All they've proven is that you're weaker than they are. So you have to assume when you're treating athletes that their hip abductors need your help. And Yanda's patterns tell us the muscles that are prone to shortening and contracture, which is why my protocol for athletes is very much focused on triple extension. Regardless of muscle testing, their glutes, their piriformis, and sometimes even the lower rotators are getting treated. Remember how rotators are very important for being able to cut right or left. That rotation is hugely important for avoiding knee and ankle injuries. The rotators are important. So gluteus medius, piriformis, hamstrings, the gastroc, soleus, and then in the front you've got to look at quads, all of the triple extension muscles, plus the inhibitory hip flexors, the psoas, the TFL, and I already said quads, but rectus femoris, very, very important. And you'll see at least on football players, sartorius gets injured. You will not see a lot of sartorius injuries on your average patient, but on football players, you absolutely see sartorius getting injured. So I think it has a lot to do with just all the rotation of their hips. It's just so dynamic, having to cut and shift and just very quickly change direction. So check sartorius as well. I think it's just important, if you know the Yanda patterns, you know what muscles are prone to becoming inhibited, and you know their antagonists are going to be the short tonic muscles that will either tilt the pelvis, anterior pelvic tilt, and shut off the posterior chain, or in front the pectoralis and the lats, and the pec minor, the pec major, the lats are going to tighten that upper cross syndrome, and that's going to make the back weaker. The serratus anterior will shorten and tighten, which will decrease their scapular stability and could possibly lead to a shoulder injury. For a baseball player, you've got to keep the hips, the torso, the obliques working well so that they don't overuse their shoulder and injure their shoulder or their the ulnar collateral ligament, that inside that valgus strain on the elbow. So really knowing what they're doing is going to help you help them avoid injury, regardless of testing 5 out of 5. So what I'm saying is, I believe that we need to treat muscles even if they test strong, because we know, one, we are weaker than that person. Two, those muscles need to be optimal. They need to be optimized for sports performance. So we assume that they're at a deficit. And of course, if you want to spend the money on the digital equipment like the dynamometer, the handheld dynamometer, go for it. But the research shows that when you're using it just like a manual muscle test, again, the same problem will happen. They're stronger than you. If you're going to use that digital equipment to test a pro athlete, you need to have them push it against a wall or against a table or against the floor to avoid that issue of the patient being stronger than the clinician. But again, I believe those digital devices are more useful for research and for tracking progress in a rehab situation like a physio, whereas we need to already know the patterns, the movement patterns. We need to understand the stabilization, the lateral stabilization. We need to understand sports optimization in 3 planes, and know what muscles to keep healthy for athletes. So the research is there, and I love that so many of the journals reference Yanda as the gold standard of assessment for understanding how to avoid being tricked by that 0 to 5 scale of manual muscle testing, or the 5 out of 5, and really understand that we don't just look for what's weak. We look for what's tight to understand what's weak. And really understanding Yanda's muscle imbalances is what they have found is the most effective way to either help an athlete recover after injury or to avoid future injuries. And I really think that's important. Just understand how the body fails. Then you can be a step ahead of those injuries when treating athletes. Okay, so that's enough for that. I'll bring more research in the future on other things like that, but I really think it's worth looking into how you're assessing athletes and question whether what you've been told as a dogma about 5 out of 5, the 5 out of 5 scale for manual muscle testing, actually applies for your athletes, because the research says that they're really just testing your strength and you're not testing their strength. So start looking more at the upper cross syndrome and the lower cross syndrome as your guide. Use your length testing to find what's short and what is then inhibiting the antagonists that you may have found weak on a muscle test. The muscle test is not complete garbage. It should be a binary. Is there a neuromuscular deficit? If you can do a manual muscle test and find a weakness, it's obviously something that needs help. But you cannot assume when it's strong that it's optimal. It could possibly be 15 to 20% in deficit when tested with a digital device. And if you're just writing 5 out of 5 and not treating, that athlete may end up with an injury that could have been avoided. So think about how you're assessing, think about what you're treating, and maybe consider treating things that you think are already strong, but that you know need to be strong to avoid injuries. Okay, that's it for this week. Have a good one.